Right. Good evening, everyone, and welcome. I'm William Sanderson-Mayer, the Managing Editor of MedicalBrief, and I've been facilitating these Professional Providence Society webinars with the University of Cape Town's Professor Robin Wood, during which over the past 5 months we've been looking at unfolding research and developments around COVID. This is the 5th in the series, and sadly, alas, the final. It's been an extraordinary run. We've had around 3,000 attendees, and the detailed post-webinar reports have been accessed by close to 10,000 readers. All the materials available on MedicalBrief, including links to the YouTube versions of the webinar. So thanks to PPS and of course to Robin. And let me introduce you to Robin, one of South Africa's leading medical scientists. He's the Chief Executive Officer of the Desmond Tutu HIV Foundation at the University of Cape Town. He's a member of the university's Institute of Infectious Diseases and Molecular Medicine, a National Research Foundation A-rated scientist, a visiting fellow at Harvard, and an honorary professor of London School of Health and Tropical Medicine. He serves on numerous scientific advisory boards: PEPFAR, the World Health Organization, the International AIDS Society, the International Partnership for Microbiocides, the TB Vaccine Initiative, and the Gates Foundation. He just mentioned to me now he was also attending a recent MAC meeting. So, hello, Robin.
Hi there, William.
I'm so pleased you're going to place all this discussion that we've had over the past months into some kind of historical context. As you know, as I've said to you, I can't help but reflect, without knocking the biotechnology aspects of dealing with COVID, I can't help but reflect that our most successful interventions to date are things we were all taught at our mother's knees. That is, cover your mouth when you cough or sneeze, don't stick foreign objects into your facial orifices, and wash your hands regularly. And of course, when you reach the teenage years, open that window and let's get some fresh air in this room. So let's go back to the early part of the last century, and why don't you run us through some of the influenza pandemics?
Okay, so I think the big granddaddy of them all was the 1918 epidemic, which was the H1N1 strain of virus. At the time, virology was not a particularly advanced science, so they couldn't isolate the organism. It was called Spanish flu because it was at the time of the closure of the First World War, and all the governments that were in the war suppressed the data and the scale of the epidemic, except for Spain, that wasn't one of the combatants. So that's why it became called the Spanish flu. It probably infected about 1/3 of the world's population. It killed 50 million people, and it had an interesting difference from usual influenza in that normally it's the under 5s and the over 60s that are targeted, but here it also targeted the 20 to 40-year-olds, and that was particularly devastating. As far as isolation was concerned, and these non-pharmaceutical interventions, a lot got done, but largely because of the sort of panic in the population rather than by deliberate national policies. So some of the early work that Neil Ferguson did was looking retrospectively at how effective those non-pharmaceutical interventions were. And it sort of got a bit forgotten, but essentially what he showed was that he could only explain some of the difference between the cities in America, less than 50%, by the timing and the intensity of the interventions. But what he showed was they were very good at flattening the curve but not so good at actually changing the mortality or the area under the curve after that. So as far as South Africa is concerned, it was devastating, and I think it was called Black October. We lost a third of our population in 6 weeks. And again, if you were to look back at how did the authorities cope with this, they initially messed it up in that the speed of the epidemic was largely because of the troops that came back that had picked up the infection on the west coast of Africa were given a very desultory quarantine and then sent all over the country by the railway system. So it seems as though that initial peak, which is what happens when you don't have any non-pharmaceutical interventions, really caused the increased mortality in South Africa compared to the rest of the world, where it was about 3%. So that's, got to remember at that time there were no antibiotics, so a lot of the patients died of bacterial pneumonias. There was no vaccine. So the only way they got out of that epidemic was by herd immunity, which is a little bit of a non-political word nowadays. Then the second epidemic that I'm going to just think was a pandemic was the 1957 epidemic, which was the so-called Asian H2N2 epidemic. And that was interesting in that the epidemic had been raging in China for a while, and nobody really noticed. And that's probably because of the political turmoil at the time. China had only finished its civil war a few years earlier. But then it was reported by the New York Times, so it wasn't any international organization that did it. And it seemed as though that influenza, was probably about 10 times as bad as the normal average influenza annual epidemics, but nowhere near as severe as the 1918. So it's estimated that about 1 to 4 million people might have died globally. The UK government was attacked for its passivity in that it did very little in the way of propagating any sort of control means. The next one was the 1968 epidemic, which was the Hong Kong H3N2. And again, that got first reported in the London Times rather than anywhere else. It killed probably about 1 million people, but again, typically it was the elderly people that were over the age of 65. And interestingly, it's remained seasonal, which is quite important when we sort of think what happens to these viruses. This virus, in the Hong Kong virus, has stayed around, and it's still in the current vaccine that we give. It was pretty devastating. It was carried from Vietnam and Southeast Asia by the returning US troops. And that's how it probably got to America. But, you know, there are stories that 50% of the workforce in France was bedridden at some stage. And they used a little bit of non-pharmaceutical interventions, but it was very, very ad hoc and not done terribly well. The next pandemic is really sort of more of a technical pandemic than a real one. It was declared by the WHO a pandemic in 2009, and this was the H2. This was an H1N1, so it frightened everybody because it's the same letters as the 1918 one. But interestingly, it was declared a pandemic by the WHO, but the WHO changed the definition of a pandemic at that time and took out the sort of serious death component of it and just said, well, it just is something, a new virus that's transmitting across the borders to which there is no immunity. And I was quite taken, they made that statement the same with COVID. They had a vaccine. The vaccine arrived a little bit late, so it probably curtailed it. So that epidemic was curtailed by some herd immunity and also by the vaccine. And by that time, there were ICUs and ventilators. quarantine was really very minimal. The Chinese, I think, put 21 US students into quarantine, and it caused a tit-for-tat political problem. But the hospitalization rate was about 1.5%, which is about a third of the H3N2, which had occurred in '68. So it turned out to be just the same as every other annual flu epidemic. Interestingly, the WHO was accused of conflict of interest at the time because their advisors were virologists who largely worked for the vaccine industry, which was quite interesting. So they had to set up an inquiry to see whether that had been why the epidemic had been declared pandemic. Then subsequently, we had the annual flu epidemics, certainly for the last decade or two. And as far as South Africa is concerned, we probably usually get about 6,000 to 12,000 deaths attributed to that. But as you'll see, there's a lot of variations on all these estimates. It depends what the denominators are and whether you're using excess deaths or recorded deaths. But anyway, those were the four epidemics. And if we compare that with sort of COVID, which is not an influenza, but we've got 600,000 cases, probably 13,000 deaths. So remember, we said the average annual death from influenza is about 11 or 12 at the upper limit. So the MRC has come out recently by some work which suggests that perhaps we've underestimated the COVID deaths, and they've certainly suggested that the excess deaths may be as high as 3 times that. So that would put us at a, if we can compare those death rates, at about 3 times the death rate of the others. So we're probably on probably about 200 per million deaths. It could be per million. It could be, if all the deaths that the MRC have identified, it could be up to 600. And basically that's pretty similar to Spain, Italy, UK. The interesting thing I've mentioned before is that it varies tremendously across South Africa, from about 57 per million in the north to 640 in Western Cape and Eastern Cape. So I think the take-home messages from that is, if we're just looking at pandemics, everyone was different. And in retrospect, I think most of them were mishandled. Some of the strains disappeared and some of them became endemic, which is interesting to see. I've seen in the last week some people saying it's all going to disappear, COVID, and the other one saying we'll better get used to living with it long term. We basically have no idea. And then the other thing was that predictions of the waves that came, it seemed as though places that closed down a little bit more aggressively, or particularly early on in the epidemics, suffered from second waves. But the second waves were sometimes more severe in the North Hemisphere, more severe in the less severe in the Southern Hemisphere. So there's an awful lot that we don't know. But I think we can say from those that the non-pharmaceutical interventions didn't stop the pandemic spreading across the world.
These are extraordinary figures that you're talking. I know we're not supposed to call it the Spanish flu, just as we're not supposed to talk about the China virus, all politically loaded terms chosen by their proponents for political reasons. But 50 million is an astonishing figure. It must have rendered the social fabric of the times in a way that it's astonishing that COVID appears to be doing it similarly, despite far, far lower mortality rates.
Yes, it's one of my regrets that I didn't actually speak to my grandfather, who lived as a young man through that, because I talked to him about a lot of things political. He was Fabian and a raving socialist, but I never talked to him about this. And now that I'm sort of involved with this, I really would love to have heard how they coped, but it was devastating. And I think South Africa, particularly, to lose 3% of your population in the best part of 6 weeks the scare factor must have been massive. But on the other hand, the world recovered, and the Roaring 40s the Roaring 20s took over. So life recovered and went back to normal, or an excess of normality. But again, it was the link with war. So people were coming out of the First World War. 68 one was also sort of tail end of the Vietnam War. So it is interesting how society has coped, and there have been articles recently about have we all become wimps and not coping with reality so much. But I think it's interesting to see how a couple of generations before coped with such a devastating epidemic.
I saw a very interesting article quoting Professor Neil Green of King's College London, where he said when the public estimates risk, it generally overestimates by an enormous margin. So, for instance, in the UK, the public perceptions of what COVID has wrought are overstated by a factor of 100 when it comes to the number of people that the public thinks has been infected and the number of people who've died. And not only is that interesting, but I find it interesting that that can happen in societies where there is so much information available.
Yes. I think that there's been some hiding of the data. I mean, nobody really knows what the modeling studies have really, what they've been based on or what they've been. So there's been an element of secrecy, and you told me that non-disclosure agreements had to be signed by many of these people. So I think the openness of discussion has been missing. But I also share this, that we started off by saying that we wanted to flatten the curve. And I think the 1918 data and Neil Ferguson's analysis of that shows that that's the main thing that you can get out of a policy of non-pharmaceutical interventions. But now we've sort of moved over to its infections. We're very concerned about young people getting infected, whereas the number of deaths in New York under the age of 18, I think it was 9, but 6 of them had leukemia, and there were only 3 there. So the death rate per million is sort of infinitesimally small. Whereas it's about 800 per million for the elderly group. So we seem to be very worried about young people getting infected, although they don't have any more problems than they would do with a normal influenza, and perhaps even less. But we do have this mortality and morbidity that really is addressed by the cofactors and age. But as an interesting statistic in the States, I haven't checked it myself, but they say the number of people who've died over the age of 100 is more than the number of people who've died under the age of 30. I think particularly for young people, they've sort of been told, well, you're not going to get sick. Well, in fact, I don't think they've really been told. They should be told you're not going to get sick, but we're imposing all these things on so that you don't infect the elderly and the vulnerable. And yet, I would say, looking across the globe, I'm not sure that I come across any country that really has looked after the people with comorbidities and the elderly. The UK didn't bother to count their deaths for a while. Sweden, it was the one big error that they had massive mortality in their old age homes. So we seem to have used our strategy as to try and stop the epidemic, which, as you saw in influenza, we could never do that, and not look after the vulnerables. Yeah, so an interesting take on it. But I think the fear is what drives it. So it's quite interesting. In 1918, I think it wasn't national policy to lock up and stay at home, but many places did. And you know, the stories of small towns, the postman bringing the disease in, etc. So it seems that that is a normal human response to contagion, that they do close down. I'm not sure that we do it for this length of time.
Robin, how does what's happening now with COVID-19 compare with previous coronavirus epidemics?
Yeah, so I think that might have been one of the drivers, the initial panic, which probably wasn't misplaced at the time on the information they had. But if you go back to 2003 to the SARS epidemic, it did spread. It became a bit of a pandemic. It went to 29 countries. We only are aware of about just over 8,000 cases and 770 deaths. The interesting thing is, has this RO number, and everybody's very, you know, gets, it's the talk of every tea party, and it used to be in the pub when we had such things. But the RO number was thought to be 2 to about 3.5. The big worry was the so-called case fatality rate, which was 10%, and that is that's at least 3 times higher than we're seeing in the current ones. So again, schools were closed, mass gatherings were stopped, but the strategy there was containment, not mitigation. So masks were used, and containment was achieved, particularly in the southeastern Asian countries, and most of the other sporadic cases, I think we had one case here, would be by international travelers. Then we had the 2013 MERS epidemic, which was pretty small fry. It was 2,500 cases, 850 deaths, and with an estimated RO number of over 8. Now, it's probably a lot of confidence intervals around there, but the big scare was that the case fatality rate was 30%. So this disease stayed in the Middle East, associated with camels and moving across the species, but the case fatality rate of 30% was a real worry. So then in 2020, COVID comes along, COVID-19, and early on, it was in China. It was estimated the RO number was probably between 1 and 3, or 1.5 and 3.5, and we didn't know much else except that the experience was that could this be a more pandemic version of MERS? And in which case, if that were the case, then we'd be facing a tragedy even greater than 1918. So I think that's why, especially then the modelers come and tell us that millions of people are going to die from this, because they plug these numbers into their equations. So I think that's what caused the initial shutdown across the world. If we look at our case fatality ratio rate, it's about, if you use the data that's published by the ministry, it's about 2%. But if you take the data from the MRC, probably around about 3.6, which fits in with the global. So this is less than places like Mexico and Spain. It's pretty similar to the Diamond Princess, interestingly, but it seems as though the case fatality rate is largely determined by the age structure of your population. So that if you adjust for age, then it comes right down to less than 0.1%. So in the South African deaths, so far we could say that it's between 200 per million and 600 per million, which is not too dissimilar from the UK, Sweden, Italy, and Spain. But we do have this differential in that the East and Western Cape were probably a little bit worse, and the north of the country was quite a lot better.
In fact, the politicians were not behaving unreasonably, given that they were basing their very harsh response on what had happened with SARS and with MERS. Why are they so different? Why is COVID so different from these other coronavirus, also zoonotic transmissions? What's different?
I think we have to accept that we don't know. That if you look back at those epidemics and pandemics that I described, each one of them was very, very different. They attacked different age groups. Some of them took off and then became endemic. So there's obviously a lot of forces and interactions between our species and these viruses, their ability to change. We don't really know what would have happened with SARS and MERS. I think it was a successful strategy of eradication. So they got in very early with quarantine and isolation, and early on in the epidemic you can stop them. The problem is that if it becomes endemic, you don't have any immunity, and as soon as you stop, it'll take off again. And that's the sort of problem that Australia and New Zealand are getting. They had a very effective stopping strategy initially. If the world had done that, then maybe we would be talking about COVID the same way as we talk about SARS and MERS. So I think there's a lot of factors playing here. I think the asymptomatic carriage is probably really important. So if it makes it less likely that the isolation and quarantine strategies would work. Certainly as soon as the numbers become larger, the resources you need to do that become massive. It's done successfully. We thought it had been done successfully in New Zealand and Australia, but it now looks as though it wasn't. South Korea is another one where we thought it was, and then it hasn't. Japan looks as though it's having a classic second wave. Some of them are grumbling on. We don't really know, and I think that we have to have enough humility to accept that there are some things that we don't know. Not everything is explained by an SDIR model. In fact, very little.
Well, I think this is
sorry, divided that. In this case,
given the comment about Australia and New Zealand and South Korea, it's perhaps a good moment to ask this question from Catherine Child of the Financial Mail. She says, what about South Africa? Are the fears of a second wave reasonable, given that we're barely over the top of our first wave?
So what do we know that causes second waves or associated with second waves? Certainly in the 1918 analysis of America, the cities which closed down earlier did have second waves, and the ones that didn't have second waves. So we think that that's probably related to the level of immunity that was developed and herd immunity. The problem that we have with COVID is the immune side of things is, again, something we're not quite sure of. You see a disease, I keep on saying this to my students, you see a disease through the assays that you have, and that's how you understand them. So we have serological assays which appear as though they only are present in up to 20% of the population of New York and some of the heavily infected places in Italy. So I think that I would not predict a second wave. It's interesting, the news in the last week had some sir in the UK said that we better get used to it being endemic, and somebody else said beware of the second wave. I think the one thing that the models have shown is that they can't predict the future very well. I think that the future will be determined by the immune status of the population, the carryover of T-cell immunity from other COVID and related diseases, and the serology. But I wouldn't make. But I think the interesting thing is, as I pointed out in the death rate, the Western Cape is actually a little bit worse than the global average. So it may well be, if you're an optimist, that we have in fact infected more of our population and have developed some herd immunity, but we don't have any good assays for assessing that at a population level. So the answer is I don't really know. If you ask me to guess, I'd probably bet a little bit, not too good odds, that we won't in the Western Cape, but anything could happen. But it does look as though, especially in the Western Cape, we've had a very fast upswing and a very slow decline, so that now we're moving down on our 7-day average to be much the same as the less affected provinces. Interesting, if you look at Gauteng, it was a much more peaked epidemic, and KZN was a little bit less. So you'd think the ones that had the highest rates may be the ones that will be less likely to have a second wave. As far as implementation of the non-pharmaceutical interventions, those community mobility indices, which are really fun, which Google and Apple use to trace everybody's cell phone and produce these graphs of how well people locked down, how many spent more time at home, stopped using transport, didn't go to the shops, went to the park or didn't go to the park. It's quite interesting that there's very little difference early on in the lockdown between different countries and different provinces. So again, I think a lot of the differences that we attribute to the NPI policy probably are serendipitous.
Robin, how does COVID-19 compare with other existential threats we have in South Africa? I'm thinking TB, murder, road traffic accidents.
Yeah, I think everybody has to look at TB. We have 300,000 cases of TB with probably about a 5% mortality. 80% of the population are infected. We officially have 63,000 deaths, which is roughly 200 a day from TB. WHO actually reckons that we've underestimated that number by twofold, that it could be as high as 124,000. So our TB epidemic dwarfs everything. Then if we were to move on to HIV, which of course we've lived through an HIV dreadful time from the early let's say 2000, when we had the denialism. At that time, we had 250,000 to 500,000 deaths. And again, these were young people's deaths per year. It's now settled out at about 71,000 deaths. But you've also got TB has doubled HIV has doubled the TB load. You mentioned road traffic accidents. In fact, it's the leading cause of death between the ages of 5 and 30. We have 1 million road traffic accidents a year. We have 14,000 deaths a year, which is 40 to 50 a day. Again, so that's affecting young people. I looked at the murder statistics. They're also just under 60 a day. And then if you look, you get different numbers whenever you look at deaths in different places. But if you look in death certificates and look at the causation that are given there by SA statistics, influenza deaths, they estimate at 18,000 per year. That's every year. So I think that this is a new disease. It's obviously an excess mortality over and above what we normally have. But if you want to contextualize it, everything is dwarfed by TB. HIV used to dwarf everything, but 65% of our HIV positive patients are on treatment, and that was one of the major advances that we had to decrease mortality. But that disease decreased our average life expectancy by more than 10 years. COVID is not going to do that. It's hardly going to touch our life expectancy. It's not to say that we're putting values on different people's lives. It is new. I think that we're somewhat over-optimistic about our ability to control it with non-pharmaceutical intervention. I think there is some evidence that early on we may have been able to stop it taking off if we'd have been much more aggressive. But at this stage, I don't see any historical data to suggest that what we're doing is incredibly effective. If you look at these mobility indices across the world, they don't predict which countries or which provinces are going to be more or less affected. So there's a lot of other factors taking place.
Robin, there have been a couple of questions coming in as you've been speaking, and I'd like to take you back to the deaths in South Africa of the 1918 influenza. I think you said 30%, but I think you probably meant 3%.
I did 3%, yeah.
3%, yes. Yeah. Just
no.
In South Africa.
6%.
6%. Okay.
It was 3% globally and 6% estimated. There's been some interesting books written on this. I'm trying to remember the name of the author that probably is the world expert on what's happened in South Africa. But that Black October, 6% of the population died. Sorry, yeah, it must have been a slip.
It's an extraordinarily high number. Let's move on to lockdown in South Africa. What did it achieve? Did it achieve what it set out to do? And again, we've had a number of questions saying, where do we go from here?
Okay, well, I think the first thing about lockdown is, did it actually do anything? Did it change behavior? And I think it probably did. I mean, I'm just looking through those mobility indices. Public transport use went down by 80%. In the UK, it went down by 70%. Visiting retail outlets and recreation decreased 80%, UK 75%, supermarkets 60%, UK 30%. Workplace, we weren't quite as high as the UK. We were about 50% and they were 65%. The extra time in the home was about 25% in both. So I think that the scare factor and the normal human behavior to avoid contagion was pretty similar virtually everywhere. And I think especially in the early days, the fear element, we didn't really know what was going to happen. And I think the lockdown was probably well received at that time. I think that part of the problem is you're asking, I can say, I get some idea of whether the lockdown was implemented reasonably to change behavior, and I've shown you those data. The next factor is, how do we know what would have happened if we hadn't have locked down? Well, as we go back to the 1918, it doesn't look as though those interventions stopped the contagion spreading. They did stop, they changed the shape, and Ferguson talks about that, takes out the peak, and that does decrease some of the mortality. But flattening the curve after that doesn't really change the area under the curve. If you halve it and then you have a second wave, the area under the curve is the same, the number of deaths. So I think the models, I'm pretty convinced that the models were overly pessimistic, that the base case that they had of the millions of deaths that were going to take place in countries was misplaced. And I think that the other thing that worries me a little bit is that we compare, countries. So Portugal does much better than Spain. So we immediately say, well, let's look at the lockdown, because we assume that the lockdown is incredibly effective. And I think that's an assumption which is not justified. It has some effects. It certainly changes and flattens the curve, which is what it was sold to everybody initially, that it would overwhelm the health services. In South Africa, even though we are in the Western Cape as bad as most places in the world, we didn't overwhelm our health facilities. We stressed them, but we didn't use the extra capacity that had been built and had been closed down. So then, we said, we don't think it's quite as good as it's been sold. We don't think things were quite as bad in retrospect as they were predicted. But what's the harm of the lockdown? And even organisations like the WHO and UNICEF are saying, well, 40 to 60 million children are severely impacted by this, and that maybe over 1 million of them will die because of lockdown. So I think I do feel that the young are taking the toll for this disease. They're losing their employment opportunities, they're losing their education opportunities, and in South Africa we've had 10 deaths under the age of 18. So I can see that people are worried about old people getting infected, but there must be more intelligent ways of protecting those than penalising the youth. One of the other things that I looked into was the efficacy or the effectiveness of school closures. And as usual, the models are everywhere, so it could be reasonably effective or it could be totally useless. Models going back to each of those epidemics, there's a model that I do hold in quite high esteem from London that looked at the 1957 epidemic and suggested that in fact the effectiveness of school closure was very dependent on the RO number again, so that when you had very high RO numbers, the effectiveness of closing schools was very little, whereas the other way around. So there's many variables that need to be looked at, and I think models have the ability to sort of help us with these, but we've got to look within the framework of normal mortality, and with a country our size, we have 500,000 deaths a year, which is about 1,200 a day. And people say, well, one COVID death is a death too many. Not if you've got to have the balance, the benefits of these quite draconian interventions, and they're not without consequences, particularly for our young people. So it's not to make it easy, but I'm not sure that there's public debate and transparency about these factors. There's been a sort of pouring on of fear. When I talk to young people and ask them what is their perceived risk, it does seem as though it's much higher than is really the case. And I don't know whose fault that is, whether it's the media. So it's a complex situation, but it does need to be put into some perspective, and I hope that's what we're doing here, in that it's not to minimize it, but it's certainly we're facing other threats which are manageable, and we don't manage them. So over-managing this one might not be the smartest thing to do.
So we don't take cars off the road because of road traffic accidents. Reading between the lines.
We don't treat TV properly either.
Yes, absolutely. You're basically saying you don't see a medical scientific reason for a second lockdown, whatever the politicians might do. I mean, they chop and change from weekend to the weekend. But scientifically.
So I've got a little bit of a problem with a national policy. I can see that it might be practical to do that, but I mean, it seems as though the disease has different needs in different parts of the country. I think that the fear of children taking the disease to other people is real, but I mean, you see headlines like a boarding school has an outbreak of COVID. Well, if you'd heard that there was an outbreak of influenza in a boarding school, you wouldn't have the same hysterical reaction. The problem is sending them home and to everywhere else. So I think we have to accept that it's a tricky one of how to open schools. There's different ages. As usual, when we don't know anything, some people are very strong to say children don't transmit, and other people say, oh yes, they do. We just have to admit that we're not sure. But there could be some gradual stepwise movement on these things, and very close monitoring of the responses, and a sort of more intelligent approach to it rather than these draconian interventions. I mean, our testing capacity has increased considerably now, so we can use tests perhaps in a more intelligent way. You know, for instance, if you are at risk, why do I need to lock you up for 2 weeks? Why can't I tell you to be locked up for 3 days and then do a test and get a result back to you? You know, there are other strategies that we can use that are more strategic and not that difficult, but better than just closing everything down, condemning people to poverty and to the damage that's caused by that, and withdrawing them from normal healthcare. It seems like TB tests are about 50% of what they previously were. So the costs of this are great. The initial implementation was fine, but I think we have to be a little bit more thinking and open debate about these issues.
In that regard, Daniel Machala makes the point that the caution about infection in young children was more about them taking it home to their elderly, at-risk parents and grandparents with comorbidities than fear for them.
Well, that's why I said a boarding school. I gave you the example of a boarding school where they don't actually go back. But what we did is we sent them back, which doesn't seem to be the cleverest thing to do. And the way that you know, if you, what we almost did the same thing as we did in 1918, in that we announced we were going to close provinces, and everybody left the Western Cape and went back home in order to disseminate the disease. So, you know, travel early on is really important in all those epidemics. I agree that the question is, how much cost can we put on the young people to protect the elderly when there haven't been proper strategies to protect the old people? I mean, you know, now we've got the testing capacity. Why can't we educate and test all the workers in healthcare settings to make sure that they're not infected and that they're fully aware of what? None of that's been done anywhere in the world. I mean, you know, we mentioned Sweden, and that we did quite well on containing the infections in younger people, but you know, the old people died. So I think it needs to be thought through, but I'm not impressed by any global policy to try and protect the elderly.
I want to switch back because there are a number of questions around TB. The one from Elizabeth Murray is, please repeat the figure for TB number of deaths a day here. And the other one is from Beatrice Setzer, I think, Karen Corrigan, asking, how many children die yearly of TB in South Africa?
Oh, that's an interesting one. So I don't actually, I have to admit, I have the figures straight off. TB is pretty lethal for very young children, but between the ages of 5 and 14 is a period of life which is called the golden age, where TB, clinical TB, is incredibly rare. And one of the aspects that I research on is that that age group actually are acquiring TB infection at a high rate, but don't get disease. The disease starts in girls, and we think it's probably related to the onset of puberty, 14, and boys a little bit later, and then it peaks in young adulthood. So I'm not a pediatrician, so I don't actually know what the figures are for infant mortality from TB, but I know that from the ages of 4 onwards, it's very, very small numbers.
Chris Lewis asks, any new insights into the role of cross-immunity between coronaviruses and therefore more rapid establishment of the so-called herd immunity?
There have been papers coming out talking about T cells that recognize epitopes. I think it's still largely a data-free area. We need better tests. I discovered that the serological test is now being allowed to be used in South Africa. It costs about 200 Rand, and I must admit I was very tempted to take my family off to just see that. But I mean, there may well be, that's just checking for antibodies. But everybody that I speak to thinks, oh, well, I might have had something that was like COVID, and or I would certainly like to know. I have a student of mine that's been working in London Teaching Hospital, and he was tested as they tested everybody, and he came back positive. And I actually congratulated him, and he felt really good about it because he had to go back to Cyprus to visit all his elderly relatives, and he felt much safer because he'd already got evidence of previous infection. So I think the immunity is key, and I'm afraid I don't have any new data on that, but I think it's watch this space.
E. Miller asks, could one consider SARS-CoV-2 closer to the HIV pandemic, with the respiratory system as the entry portal, but not the real cause of death?
That's quite an astute observation. Yeah, I think there's been some good news. I think that medical science has moved on developing the tests relatively quickly. Obviously, there were problems with supply chains. The pathogenesis of the disease is fascinating in that it looks as though early on it may be more directly related to the virus and its occupation of the receptors, but later on some sort of immunological disturbance. And obviously those are the more advanced patients, and those are the ones that contribute to mortality. So, the whole idea that we're talking about herd immunity, and yet we're giving the most sick patients steroids to damp down their immunity, shows you the complexity of what's happening in individual patients. And steroids seem to help the very sick, are moderately okay with the ones that just need a bit of oxygen. And it certainly looked as though they might be harmful for the earlier ones, or they didn't reach statistical significance. It certainly trended that way. So, yeah, that is interesting. I probably wouldn't put it so much as HIV as more TB. I mean, we know that most of the pathology of TB is actually immunologically determined. The organism itself doesn't secrete nasty things that destroy cells, but suddenly the immune system wakes up and starts causing cavitatory dissolving tissues, etc. That's not due to the organism, it's due to the immune response, and I'm sure that there's no reason why that wouldn't play a part of COVID.
Well, there's so many competing inputs into how it should be dealt with, and in your view, how do you feel the World Health Organization has performed, and science generally? Give it score it, and for that matter, governments, our government specifically.
The WHO is probably a bit easier to, because they do announce and you know exactly what they are suggesting. But I think there was a delay in declaring the pandemic, and I wonder whether that was because they got egg on their face from the 2009 epidemic. But it seemed as though everybody knew there was a pandemic before they announced it as such. And then I actually found the statement quite jarring, that they said this is a new virus with no immunity. And I remember turning around and saying, how do they know there's no immunity? And then there's a series of flip-flops. So masks were dangerous. And, somebody working my organization was tweeting this WHO thing. And I said, well, wait a bit, I suspect that we're going to have to use masks. So don't tell everybody they're dangerous, because there's no real evidence that they're dangerous. You can debate how effective they are and what sort of mask or respirator you're talking about. Then they stand up and say, well, asymptomatic infections are not important. And then I think it was a day later, they had to flip-flop back and say, well, maybe it is. My particular little fight with them is their statements about that this is not aerosolized. This is large particles that are being spat at people and hitting them. That sort of upset a lot of aerobiologists around the world who've written open letters and signed by hundreds of them to say, no, this is just not true. I've been trying, that's my input to in some of the South African groups looking at this and the government. That's largely driven by the WHO. WHO also has this wonderful thing. They say, well, we can use 95 masks. We don't have many of them, but we'll use them for aerosol generating procedures. Right? No one's ever shown that any of those procedures generate aerosols, but it sounds nice. And, you know, I pointed out that actually putting a tube inside another tube doesn't produce an aerosol, but it doesn't require my nose to be 3 inches away from the infected patient. But, you know, they've invented things like that. And therefore, N95 masks for healthcare workers are only applicable to these procedures, which I can understand. Initially, people said, well, we don't have enough N95 masks, so therefore we'll give them to the people who need them most. But don't try and pretend the science suggests that that's what you should do. Then one of the other things is I don't think we're using tests very smartly. I mean, there's a lot of immediately come out and say immune passports are going to be rubbish and no one should do them. I actually think that testing will be one of the modalities which allows us to open up our industries and our travel thing. So I can see they're torn, but I don't think they're looking at the data and creating hypotheses from it. I think they're doing it the other way around. They're trying to cherry pick studies to fit with their preconceived ideas. So you've touched on a sort of raw nerve of mine. WHO are needed. We do need people to identify these pandemics and epidemics very early on, but you know, it is a little bit too political, and I'm not sure of the quality of the science. And I think that's why they're getting, I mean, to get open letters written by hundreds of world experts means that you probably should consider that you might be a little bit out of line. As far as government, I think, and you know, I've got to be sympathetic. I mean, they had to do something early on. There was a lot of fear, and the initial thing they should have done was to close down transport. And that's what basically all those pandemics that I mentioned to you, at returning soldiers, Vietnam, 1918, returning soldiers distributed all over we knew that the disease was going to be imported, but we didn't really put enough resources into containment at that stage. I came back from Boston at that stage. I was aware of the risk and I put myself into quarantine, but the highest risk I had was in Cape Town Airport, being crowded into a room with a whole load of Italian tourists that had just come off a flight from Italy, and crowded together whilst we queued up to have our temperature taken. That wasn't the smartest thing that I thought that I could have gone through. So I think we missed the early control opportunity, but so did many other people. So I think the concept of flattening the curve, you know, the models that they worked on, you know, I think that it was the appropriate way of responding, and it seemed as though either the models were wrong or we did flatten the curve. So that's a positive. I think the lack of nuanced rules and regulations. I came across a quote which you may well know, that authoritarianism, crisis is the rallying cry of the tyrant. So as soon as you have a crisis, then it allows the authoritarians to impose, somewhat ridiculous sort of, but very freedom-curtailing activities. I couldn't really understand when I looked out of my window why surfers were being arrested for surfing on the waves. Didn't seem as though that had anything to do with the transmission of COVID. So I think that the inability to nuance things, I think the worst thing you can do is steal the money that's being put aside for controlling the epidemic. I think that is, cost effectiveness models do not take into consideration corruption. So I think that has to be the lowest of the low. I don't like the communication strategy has been, I can see that they've tried to do it. The minister does put out some data every day, but there's not much in the way of access to the important data to discuss, to see what's happening across different provinces, different age groups. So I think the secrecy is not good for debate. And as you just mentioned, I don't know what the current exit strategy is.
And probably now there's the government. Robin, the one thing that occurs to me, if you look at South Africa specifically, is the one thing the scientific community here seems to have done really well is that it has spoken out, it has taken on government, and it has not allowed itself to be cowed, which is one of the few bright spots in the whole picture. I see we're really, really late and with still dozens of questions. I just want to ask you to pick up one thing, this latest possibility of second infections.
Yes, I think it's interesting. It's a beautifully done study. I mean, I think that to show that it's a different virus the second time around from the first, but the patient's not actually sick with the second infection. So I think it's really interesting. I think it's an observation which has been very carefully studied and very well studied. But what its relevance is, I'm not sure. You would expect a spectrum of immune response to anything. So some people have very robust immune responses and some have very weak ones. There's something interesting about this, but I'm not sure that on the basis of this, that we can say, well, there's no long-lasting immunity. Therefore, disaster is coming. It's interesting. Like most scientific observations, they need to be reproduced in different places to show that this is relevant. And then we need to make some assessment of how generalizable is this. So interesting, but I don't know what it means.
Thank you so much, Robin, for this webinar and also for the whole series. I think you've given us an incredible insight and a very accessible insight. Thank you so much for doing it, and thank you for PPS for sponsoring it. And perhaps we'll take it out later on, and apologies to the very many people whose questions I were unable to take this evening.
Thank you, William. Oh.